Thank you all for joining today. And good evening to everybody in the audience as well. Saturday evening, and I'm sure some of you had to cancel your plans to attend this extremely interesting discussion today. For those of you who are joining for the first time and have not heard of Nivarna before, Nivarna is a public health information advocacy platform which was started in 2022. And the aim is that we want to bridge the gap between public and public health by making information which seems very complex. We want to make it easy to understand, connected with stories, and we want to make it accessible. And with all this, we hope that we will ultimately empower people with the right information. And once public health enters mainstream discussion, everyday conversations, we hope that people will understand what is lacking in the country, what needs to change, and then ultimately demand a change. Public Health Forum is one of our initiatives where we have solution-oriented discussions to problems with experts in our panel and experts in the audience. And today we are going to discuss health financing in India, a topic that affects every single one of us. And we know that health is the core of each person's being. And I'm sure each one of us has either struggled themselves or seen somebody else struggle to access good quality, affordable healthcare in India. And today we'll try to understand why even 77 years after independence, India's health system is struggling to cater to the needs of its people, and what role does health financing ultimately play in this? And to discuss this, today we have three highly experienced and knowledgeable experts. Our first speaker, Dr. Indranil, is a public health researcher, specialist in health economics. He has a PhD in public health, health economics, an MPhil in public health, MA in economics, and he's also a visiting fellow at Center for Social and Economic Progress in New Delhi, and has immense experience of teaching and researching in health economics and healthcare financing. Thank you, Dr. Indranil, for taking our time for the session today. Our second speaker is Sujata Rao ma'am. She is a 1974 batch IAS officer and the former Union Secretary of Ministry of Health and Family Welfare, Government of India. She has served as administrator for 36 years, and out of those 36 years, 20 years she has spent in the health sector. And she's also been the Secretary Health of the state of Andhra Pradesh. So she has worked at the state national level. And she has written a wonderful book called Do We Care? India's Health System. This is a book, and I would request everybody here in the audience to please read this book. If you are working in India and you're working in health, this is one book you should definitely read. Thank you, ma'am, for writing this book. I've read it thrice now, and every time I read it, my understanding keeps improving. So thanks a lot for writing this book, and thank you for joining us today. Our third speaker is Rema Nagarajan. Rema is a dear friend and a journalist in Times of India. She reports on development issues and health-related topics, and she was a Fulbright Scholar 2005. She's one of the very experienced data journalists in the country and a very loud voice when it comes to keeping India's healthcare system and healthcare providers in check. Her reporting on these issues has been crucial, and I'm sure a lot of you will know that her reporting was a major reason why accepting gifts from pharmaceutical companies in India became illegal for doctors. So thank you once again, Rema, for all the work that you do and for joining us here today. My name is Parth. I am a community physician and a public health researcher and the founder of Nivarna, and I'll be moderating today's session. I request all participants to please share their questions in the chat box, whether you are joining us on Zoom or YouTube, and we'll take your questions up at the end. And for those of you who have joined us on Zoom, you can raise your hands towards the end, and we can ask you to unmute yourself that time and ask a question. So now I think we can get started with the main discussion that we are here for. Over the past few months, I've seen that health financing in India has become a very hot topic, and everybody is discussing it. But at the same time, when I go through tweets on Twitter or LinkedIn posts, I see a lot of misunderstanding. And that's the reason why we organized this session today, to reach and understand the very basics of health financing. And to start with you, Dr. Indranil, where does this money come from? When we talk about health financing, we come across a lot of terms called cess, direct, indirect tax. There are people arguing that, I am paying tax, so many people are not paying tax. I should get services, others should. So there's a lot of this discussion happening. So could you shed some light on who is funding our health? Where is the money coming from? And who ultimately deserves a good public health system?
Yeah. Thanks for this wonderful opportunity. I was just recollecting the year I started understanding or reading about health economics is when Dr. Sujata Rao had published under her leadership the National Commission of Macroeconomics Health India report. I think, one of the foundations on India's health financing, and that report had played a major role in shaping how health financing has been over the many years in the country now. And we really sometimes look at some of the important chapter background papers of the report still. So it's a great honor to be here in this panel and with also very eminent and all journalists like Rema here. So I'm really thankful to all of you. Coming back to the main question, how health is financed in India. So basically, if say 100 rupees is spent on health, almost half comes from people's pocket. When I'm saying half, I should also mention that this could be an underestimate. And we have written that in the recent past, we have seen that the national health account, which is a satellite account of the India national account, which tries to find out what are the various sources of money spent on health, where it goes, what kind of services purchased, is showing a continuous decline in out-of-pocket expenditure, and we have challenged that. But that's a separate discussion. But to start with, I must still also emphasize that a lot of money still comes from people's pocket, which is unfortunate, which creates inequities, which creates barriers to access, which pushes people to poverty. And there are estimates also floating around that almost 5.5 million to 6 million people every year, 5.5 crore to 6 crore people every year gets pushed to poverty because they have to pay from people's pocket. Now, what is the alternative? Across the world, much of healthcare needs, health financing needs of people are borne either by the government through general government resources. Large part of this general government resources is the tax money. Uh, and then there are few other models also. One of the prominent is where employees contribute to a fund and government sometimes contribute, and that's called social health insurance, where some mandatory tax deduction from people's salary takes place, and that fund is used to finance it. So there are prominent modes of financing. But in many developing countries like India, we see a mix of general government revenue financed healthcare system, uh, like say our tax money going to funding public uh, hospitals, dispensaries, PHCs, and all of that. And then we see that a lot of money is coming from people's pocket. In India, also, there are social health insurance schemes like ESIC, where employees contribute. One of the best health schemes in the country is the central government health scheme or the defense uh, health scheme. These are for employees of certain category, the central government, the civil servants. But largely, a lot of people need to pay from their pocket to finance healthcare. So that's the overall picture. Now, while coming to taxes, cess, and all of that, we need to also emphasize that taxes are generally progressive, but there are mainly two broad categories of taxes. The direct taxes, which comes from when we earn some income, from that a part of tax goes, or say somebody has earned a profit, some part of that profit is taxed. So these are some of the direct tax, or say taxes on wealth transaction and all of that. So directly collected from people who are earning. But then there are indirect taxes. In India, goods and service tax is one of the prominent major source of indirect tax. These taxes are paid by every citizen, whoever is using any commodity. Some might say that people who buy primary commodities, mainly food and other items, do not pay tax. That's not true, because every food that is carried from one place to other is there are petrols or other things used to carry that food, and there are taxes. So one cannot key point to react to your question is everybody is paying for our health system because everybody pays tax, every citizen of the country. So this misconception should be done away. The other point that you are making is on the issue of cess. Cess is a tax on tax. So in India, there is an education and health tax imposed by the union government of India. And the thing is, other taxes, for instance, GST or say income tax, that different direct taxes, shared between states and union government. But in case of cess, the body or authority that is imposing, which is the central government here, can retain the whole proceed from that cess. So that makes it a bit tilted towards union government, the collection of cess. So there has been a tendency of collecting more money on cess. But the unfortunate thing is, much of that is not even going back to the sectors it is being collected for instance, health and education. So this is overall reacting to the to your point. I wanted to also talk about the recent trends in financing, public financing of health, if that is okay, or I can come again and show those. I have few slides to show, so up to you. I can come back again after we hear from Dr.
Yeah,
Sujata.
we'll come back to that second part of
Yeah.
it. So what I've understood from your explanation is that most of the money is still coming from pockets of people and not from the government. So almost half of it, people are paying themselves from whatever they are earning. Even though they're paying all the tax, they still have to pay for extra for the health. And across the world, there are different models, but mostly developing countries have a model where government also pays and people also pay. So it's a mixed model. But for our country right now, even though everybody is paying tax, there is a misconception that only few pay tax, even though everybody is paying direct and indirect tax. And cess, even though it's sounds like a tax which is going for a particular objective, it mostly goes to the central government, and states do not get it. So thank you for bringing out those points. My next question is again one misconception which I've commonly come across, which is that why should we care about central budget when health is a state subject? And I feel, Sujata ma'am, you would be the best person to answer this since you have been at the state and the central level. People are often confused. Why should we care about central health budget when state is supposed to spend on it? So what does it really mean when we say that health is a state subject? And what is the role of central and state budget then when under the constitution, health is given to the state?
But, the health is not a state subject. As you see, the concurrent list, there are three lists: union list, the concurrent list, and the state list. So health is a state subject for public health, delivery of hospital services, and certain listed items. But again, there are several items in the concurrent list, which is list 2, where it is concurrent responsibility of both the central government as well as the state government. Now, what are these? These are very important aspects which are in the concurrent list. Say medical education, reproductive health and family planning. And then you have infectious diseases which cross borders, and other things like trade, sports, whichever trade ports where health is concerned. Like that's why you have airport health authorities and you have port health authorities and so on. So disease coming from outside, and there's several aspects of drug control also. For example, the drug regulation again comes under concurrent list, where is the DCGI, that's the drug controller who has to approve any drug or vaccine that is being imported for use in the country. So there are several aspects of healthcare which fall in the concurrent list, and that is the reason why right from independence time we've had a central government providing funding to the states for, if you remember, family planning in the beginning, then reproductive health care. All the national health programs all deal with TB, malaria, leprosy, HIV/AIDS, all infectious diseases, a large amount of immunization, which are vaccine preventive diseases. All these come under the infectious disease control programs. So reproductive health, and then colleges comes under the central government and the state government together. So, under the country, and therefore that is the reason why central government has to also be a partner and fund the healthcare budgets. But of course, what is happening is over the years, there has been a slight amount of encroachment into the state powers. And there is a little bit of lack of clarity. For example, I feel the NEET exam admission into colleges should be done at the state level. Why should, when education and is a concurrent subject, why should NEET not be done at the state level? But then there's an argument on the other side why it is to be controlled for standardization purposes by the central government. At the same time, again, they do fund, we do get funding from the central government for sub-centers, PHCs, and community health center, which is a primary healthcare center. It's a service delivery completely under the control of the state government, because the state government is responsible for delivery of services. But at the same time, you do have central government giving huge amount of money for the primary health care, which increasingly has also included non-communicable disease control. Under the Ayushman Bharat, they're giving money for infrastructure development of CHCs and PHCs and so on, and district hospitals, strengthening of district hospitals, and covering non-communicable diseases, which are not really the mandate constitutionally by the central government, because central government is only responsible for infectious diseases, not non-communicable diseases. So there is a slight amount of encroachment, you might say, or expansion of the health. So there is a little bit of ambiguity in the division of powers between the central and state. In medical education, drug regulation, there is a overlap of jurisdiction, which is causing a lot of harm and needs to be addressed very quickly, because there are pros and cons on both the sides. And in terms of delivery of services, I think there needs to be a clarity as to who is accountable for what. I'll only end with this sentence, that if anything goes wrong, immediately central government takes a back seat and says, health is a state subject. We are not responsible. So if you remember, even during COVID time, they said you buy your own vaccines if you want to, you can do whatever you want and so on. But that's not true. COVID management is as much a central government concern as it is of a state government. So they're bound to give funding to the state government. It's not a health subject. State is a health subject kind of argument you can get away with, because it comes under infectious diseases. So this, ambiguity needs to be sorted out. It has kind of been coming for a long time. But finally, the central government funding is largely welcome to the state governments because the state governments are really constrained for funding. And if you notice, if you take any state government budget, almost 90% goes for salaries. Very little is left for purchasing drugs, equipment, building infrastructure, and so on. And that is where the central government funding fills that little gap. And that's why you find increasingly state governments getting dependent on central government for that little oxygen to make programs run. It's not a healthy thing, but then that's how it is. And we'll discuss this a little further later on.
Thank you, ma'am. So this, again, a huge misunderstanding when we keep saying health is a state subject, but it's very conveniently used even by the central government. And this happened recently in the case of tuberculosis as well, when drugs, there was out of stock, the ATTs were out of stock. And then again, central government said health is a state subject and states have to buy their own drugs now. So I hope everybody in the audience has heard this and understood this, that even though we say health is a state subject, there are a lot of things which are under control in the concurrent list. And once it's in the concurrent list, the center has say over state.
It's a shared responsibility.
Shared responsibility. But once the center says something...
So typically, how does the sharing take place is on the centrally sponsored schemes. The central government gives 60% of the money and 40% is met by the central state governments. But very often the central government of this 60% also consists of drugs in kind, both in cash and kind. So typically for TB, malaria, or leprosy and all that, it will be, the assistance will be in the form of drugs. which is procured centrally, and a bit of it is given in cash for your logistics, petrol, and appointment of some key personnel, and so on and so forth, or equipment or something like that. So it's a shared responsibility.
And but overall, it's the center influencing states.
Because of dependence of the state governments. State governments have their own money, like Kerala and Tamil Nadu doesn't really care for them, but then they need the money. So they agree to all the conditionalities, like the branding for the Ayushman Bharat and for the insurance scheme. So there's a lot of politics in it all.
Yeah.
Yeah.
I'll come back to you, Dr. Nanal, this time with the same question that you've written an article recently in the Hindu where you talked about central and state funding for health. And we have noticed that even though the central funding is decreasing, state funding is increasing. And again, I found this responses again on social media were quite confusing as to where was this money for the states coming? How can state funding go up when central funding is going down? Could you shed some light on that and explain to us how does this whole funding mechanism happen at central and state level?
You're on mute.
Sorry, yeah. Slides are visible?
Yes.
Right. So, before coming to your direct question, I need to emphasize on this point that overall public spending on health in India is way low compared to countries which are at similar levels of development. For instance, countries like, say, even if we compare, say, ourselves with countries like Sri Lanka, Vietnam, Indonesia, though Vietnam might have a much higher income compared to India, but say even Sri Lanka and Indonesia, they spend 3 times in terms of public spending on health. And countries like South Africa, Brazil, China, Thailand, Malaysia, more than 10 times. So that's a very important critical point to note that overall public spending is very low. Now, if that's the graph on the left side. If we look at the graph on the right side, where I'm trying to it's a crude graph, but just to portray this point that if we compare the countries in terms of per capita income, because public spending on health depends a lot on how much is the purchasing power and per capita income of country. And if we compare countries which are around India, say slightly higher or lower per capita income, you will see, and that's the x-axis. On the y-axis, we have the per capita government health expenditure. You will see that India remains at the lower level of the spectrum. Countries are at much higher levels spending more. That's one key point I wanted to make. But now, coming back to your other point, how is it the case that the center is spending less and states are spending more? Here, I wanted to bring the union and state government spending on health as a percentage of GDP over time. The red one is the union government, and the blue one is the state government. And you can clearly see that over time, state governments have spent more money on health. Now, whereas union governments spending as a percentage of GDP remained almost stable. During the COVID year, there was some increase, but that increase is also largely because the GDP tanked, and as a percentage of GDP, health spending looked very high. I'll show some pictures where actually we'll see in real terms when how this is panning out. The other important point I want to make is that the post-COVID, if you look at the trends between union, and this I'm quoting from the National Health Accounts data, so more authentic figures, and also some of the latest figures I have compiled from Reserve Bank of India data and union budgets. And if you look at, say, the post-COVID trend, you will see that state governments have sustained their public spending on health during post-COVID era. In the sense, the blue line is still going northward. Look at union government trend. There is a continuous decline and slowdown. So this also, in some way, shows the changing in priority. a lot of state governments are putting their own resources. See, there is also, since the 14th Finance Commission, there is a greater share of tax devolution going to states. And it would be it is very encouraging to see that post-COVID, states have realized that we need to spend more money on health. So this is a positive thing that I wanted to show. Uh, as far as the union government's health spending is considered, and if we, I want to emphasize on the red line at the bottom. Here we are taking out the impact of inflation, price rise, and trying to see if prices remain same, what would have been the spending by the union government. So the blue line is without adjusting for prices, so you can see some increase. But then look at the red line. Actually, there is a decline compared to, in real terms, compared to what was happening in post-COVID. Even so, the actual expenditure, which is for 2022-23, the latest available for us, is less than what was spent in 2019-20. So healthcare that you could have provided with this money in 2019-20 was no more available or made available by the union government in 22-23. Now, the 2023-4 figures and 24-5 figures show some increase, but please also note that when actual expenditure comes, there could be further decay. This is a very disturbing trend, and we need to highlight this. The other point that we want to bring it here, which is how much is the health budget as a share of, say, union government expenditure. Union government spent on many things, defense, it spends on education to some extent, it spends on many other priorities, agriculture, various other things. And we see that priority accorded towards health has been declining. And if we compare 2019-20 and current period, this is again a very important thing for us to note and take and argue that this is not. The last point I want to make, and one of the crucial point, the National Health Mission, which is a centrally sponsored scheme where central government is spending money, but state also pitch in. And over time, the union government share has declined. But what we see here is the trend in real terms for central government allocation has been on a declining pattern since 2019-20. And this is very disturbing. One can argue that the share would go down because now states are supposed to spend. But the idea is, in a condition where the overall spending is low, you need to, even if state share is increasing, center also need to put in more resources on this kind of schemes. NHM has played a major role in improving health system. And here the issue is, like Sujata ma'am also said, states like Tamil Nadu, Kerala might still be able to generate resources on their own. But what happens to Madhya Pradesh, Chhattisgarh? They depend on schemes like National Health Mission to fund their health budget. And there, these schemes are crucial. So I'll stop here, and if there are further issues, we can discuss again. But I look forward to hear from, yeah. Right.
Thank you for sharing that. Overall, it looks that the spending is quite low, and it's been quite low for a long time. And I'll go to Rema now. Rema, you also have talked about this healthcare financing and the central spending in your recent article. And again, I've noticed that people bring up this point that the absolute number in crores has been going up. So the argument people bring is that previously it was 60,000 crore a decade ago, now it's 90,000 crore. So government is spending more. But in your analysis, you have shown that if we take inflation into account, it's actually going down. So could you talk a bit more about that? How did you, what inflation is for somebody who doesn't understand that? And how did you take that into your analysis and come up with those numbers, and ultimately what those numbers really mean?
Parth, could you just pull up that table, please?
Yeah.
So yeah, it like Indranil was saying, most of it is showing a decline. But even when we look at, he also talked about inflation, but he was talking about constant prices and how when you look at that. So in layman's term, let me explain it. Like what you bought, what you can buy for 100 rupees 10 years back is not what you can buy for 100 rupees today, because the value of the rupee keeps going down and things become more and more expensive. And we have to find a way of calculating that. That's what you mean by basically adjusting for inflation. So, for example, what is the value of 83,000 crores in 2018 compared to 56,000 crore, which was spent in, say, 2013? So this kind of, you're constantly trying to equate to, this is looking like a huge jump. You think that, government was spending only 56,000, now they're suddenly spending 83,000. So that's a lot of increase. So it looks like a huge increase, and the government will only talk about these absolute numbers. But we also need to see whether we can compare these two numbers, and how do we compare them when actually prices of things have gone up. So what we do is, there is something called a wholesale price index, which the government brings out to allow this kind of calculation to be done to see what the effect of inflation has been on various things. But this is generally going to give you a general inflation. Now, general inflation can be calculated by using wholesale price index, which the government puts out. But the reality is healthcare costs actually are rising much faster than the cost of most other things in this country. Whether it is food, whether it is transport, most of these things, healthcare cost is rising very, very fast. And hence, even when we do this inflation adjustment and show you a figure, which is already showing that the allocation is less, it doesn't quite capture the fact that what you're allocating is not going to be enough, especially for healthcare, because healthcare costs are rising so high. Now, let me give you an example of that. On 12th April 2023, government said that for central government health service, OPD consultation, the cost that they're going to reimburse for OPD consultation went up from 150 rupees to 350 rupees. So 150 rupees was fixed in 2016. And 350 rupees is being increased in 2023. Now that, if you look at it in government terms, government will say, oh, 133% increase ho gaya. That, so much has been increased. Similarly, ICU charges earlier per day was 862 rupees. And in 2023, it went up to 5,400 rupees. That's a 500% jump. So that gives you an idea of how high, how fast and how much healthcare costs are escalating. Now, suppose the government budget for consultation for 100 people in 2016. So for 100 people, government would be spending 150 rupees per person, 15,000 rupees, right? So in 2016, government spent 15,000 rupees. Now in 2023, the government will say, I'm going to increase my budget by 100%. So I'm going to double it, go from 15,000 to straight 30,000 rupees. And government will be very proud that we have increased the budget by so much. But in 2023, the consultation cost is now 350 rupees. So where you spend 115,000 rupees for consultation cost for 100 people, now for the same 100 people, you will not cover with 30,000 rupees. You will only cover 86 people with that amount of allocation. So which means even after doubling the amount, you're not able to catch up with the price rise. And plus the fact that in that 6 years, your population has gone from 100 people to 105 people. So actually, you are not being able to pay for about 20 people. This is the reason why government health services are always looking short. That when people go into the system is always underfunded, not being able to provide the funds that is required, because they're never being able to keep up with this what is required. By actually, when they're saying, when government says I have doubled the budget, actually what was needed was 105 people into 350, which is the new cost of consultation, which means government had to have 36,750. That should have been their budget, which would be 145% increase. Now, this is exactly why we have to adjust for inflation. Because what looks like a big increase, where you said that, from 15,000, I jumped to 30,000, that is not a great increase because you still haven't covered the same people you were covering in, say, 6 years back. This is why we need to constantly adjust for the price increase when government says that we have increased the budget allocation. So this is basically what we do when we when we do inflation adjustment. And of course, the other ways already Indranil has explained that, whenever the government puts out a budget, there are 4 ways of looking at it: past as a share of GDP, as a share of government's total expenditure, then inflation adjusted, and the 4th is what the government does, which is basically just look at the whole numbers, and then it will look very rosy and it will look very good.
Yeah, thank you for explaining it so well. I didn't have so much clarity on this concept, and now it's become very clear. So ultimately, even after adjusting for inflation, the numbers that you have come up with, the scenario could be much worse because we don't have the data on how expensive healthcare is getting.
Exactly.
And now this brings me to my next question, and Sujata ma'am, this is for you. National Health Policy 2017, we were told that we'll steadily increase health spending and reach 2.5%. It's already been 7 years. And so what do you feel has been the problem? Why has health financing been low in the country? And in a country like India, despite the health financing being so low, why do we have a state like Kerala and Tamil Nadu and Bihar, Chhattisgarh, Jharkhand? Why do these completely contrasting scenarios exist in the same country?
Well, to your first question, a simple way of looking at the center state shares which go up, which together make for percentage of health spending as proportional to GDP, is to look at the 2 components that go for it. That is the central government budget and the state government budget. We're talking about public financing. But when you add out-of-pocket expenditures and other expenditures, then the national health accounts give you for total spending as a percentage of GDP. So that could be somewhere like 5% or 4% or something like that. But public spending, that is the tax-based government spending, has always hovered around, as Indranil has said, between 1.1 to 1.3%. And this has been the reason why we health wallahs get upset is, in 1992, it was 0.9% to GDP. And we're still, after so many years of so-called economic boom, liberalization, so much of wealth and blah, blah, we still are around 1.1, 1.3. But the economic survey and the government documents will try to show that we've reached almost 2%, 1.96 or something. And we are on our way to reach 2.5%, which is the target for 2025, we will reach. That is because they add water and sanitation also. Now, water, sanitation, nutrition are social determinants, which definitely, that's a part of the social medicine. As a community health guy, the 2 things, the clinical, medical, and the social medicine. And definitely, I'm one of those who believes in the value of social medicine in terms of comprehensive primary health care with social determinants playing a very big role in bringing out disease. But then when we study globally, when we look at health and family welfare, we don't add the social determinant budgets. We very much stick to what the health, that's really speaking, a little bit of public health, but a large part is hospitals and doctors and drugs and equipment, which is medical clinical, which is the health budget. So if you really look at that, we are nowhere near reaching the 2.5. So you can try and add other sectors and say that's also going to contribute to health. That's a different way of defining health and well-being. It is not unimportant, but it's a different thing. You and I are talking about different language, because when we say we want 2.5% of GDP on health, we want money to employ doctors as per norms. We want money to improve our service delivery. We want money to establish, there's almost a 30% shortage of sub-centers, primary healthcare centers, and community health centers after 75 years of independence. So therefore, there is all this has to be met out of the budget. So this is the reason, sorry, this was the first question, right? So the component of central government has always been 0.3% of GDP. Consistently, if you see for the last whatever years, it has never really gone more. And 0.7% is the state government. Now, if you see the 2000 NHP, the second NHP, it gives you the composition. Unless and until the state government spend 8% of the revenue budgets, that means whatever is the public spending that the government spends out of tax resources at the state level, they must spend at least 8% on health. And the central government must spend at least 2 to 3%. That together will then help us to reach the 2.5%. But today, if you look at the RBI figures, RBI statistics for 22-23, not one state has reached anywhere of 8%. Maybe the average is about 5.5% for all the states. The states are struggling. So, okay, 1990, they spent 3%. Now they come up to 5.5%. It's an improvement. But then the states have to spend more. They have to allocate more budgets on health for it to reach the 2.5% overall of percentage of GDP. Now, that then brings you the larger macroeconomic thing of shared funds, because GST has now come in. And with that, the taxation powers of the state governments have been restricted. And you see West Bengal, Kerala, and all these states are fighting, saying you're not giving our dues. So, the central government is not releasing the budgets. I mean, then that brings you macroeconomics. And you have to understand those fundamentals where much of the money is being taken from the state government, but not returning. Now, the 14th Finance Commission made that, the finance commissions are commissions which are set up once in 5 years to allocate what is the proportion of the budgets of all this money that is collected in the country must go to the states by the central government, because central government is collecting all the taxes. State governments have hardly anything, some property tax, what are the other excise tax. So that's why we are becoming drunks, because they have no other source of money except liquor. So every state is forcing people to drink more so that they get money, which again has its own health impacts. But that's where you're being pushed because of the kind of tax policies that we have, you see. So therefore, now with GST, even the little lever that states had to levy their own taxes has been taken away and centralized. And the central government is not giving their due share back to the states. So states are under terrific fiscal problems. The leeway, they don't have so much of money to spend more on health and education. But then again, there's another rider. What is your politics? It again comes back to politics. You want to give money for free bus rides. You have money to give, subsidized 5 kg rice. You have money to give all these things that get you votes. Health budgets don't get you votes in that sense. They do, but they don't. I mean, it's a slow progress, right? Mohalla clinics did get some leverage for Kejriwal. So did the Rajiv Arogya Shri in Andhra Pradesh when Rajshekar Reddy introduced it. They estimate, the pundits estimate about 5% swing in favor of Congress party in 2009 because of that scheme. Now, this attribution is very difficult to make, but health does matter. But then at the same time, popular schemes are more attractive, and therefore a lot of our money is going in this populism. And so the overall fund is getting more and more restricted for basic investments like health and education. So the whole structure of financing in India itself is a very great disincentive for supporting health, which has long-term implications, but of very huge implications, because you cannot grow with a sick people. And as Rema had said, the inflation is increasing. Medi-inflation is the term we use. Medical inflation is almost 15 to 19%. Indranil will know the latest figures. So, look at the inflation over there, and the budgets are not being able to keep pace. So everything is in a very tight, you have to understand the whole issue in a much more broader concept than just the rupees allocated and rupees spent. And before I end, I don't know if I've answered both your questions. but you can ask again. But before I end on the budgets, anyone in the audience here interested in looking at public finance, there are three figures you'll find. One is at the time when budgets are announced, it's called budget estimates. These are just estimates. I'll give 100 rupees for health. In December, the actual expenditures, you know how much the states, center, everybody have been able to spend. If supposing it is going on course, then 100 will be spent. But if there's some slack, then they'll revise it. Or if the the central government is suddenly having resource crunch, they'll cut your budget. So the revised estimate then maybe shows 80 rupees. So there's a 20%, 20 rupees cut there. But finally, what really gets spent comes after the auditing is done, and that's a year late, and it's called final estimates. So do look, the final estimates is the actual spending, and that is always much, much, much lower. So if you really want to know health spending comparison between past last year to this year and blah, blah, that kind of comparison, the real comparison comes when you do the FE to FE, not BE to FE or RE to FE, because those are only estimates. These are audited figures. So audited figures means actually what have you spent, and what you spent is what gets done. You know, so if you have spent 10 rupees, I don't care that you allocated 100 rupees, it doesn't mean anything, because only 10 rupees worth of stuff is what I have got. And there is a huge difference between these figures. So you must be very careful on which figure you're taking to compare. Because very often, you know, governments will say, oh, look at this figure, then we gave this. But you must see which figure are they using and comparator. And Indranil and Rema had talked about national health accounts, which is a very comprehensive understanding of total money that the Indians are spending on health. Total, everybody. Railway hospitals to purchasing your drugs in the pharmacy, everything. But that was done, Indranil, I think in 2017 last. The national health accounts. After that, it has been only an extrapolation, I think. Nobody has done the latest.
1920 is the last, and then they have extrapolated.
So after that, it has been an extrapolation. So we really don't have the latest figure, though they're supposed to do it every year. I don't think
you mean
20, I think
the out-of-pocket. The out-of-pocket figures are based on 1718 NSS.
That's what I'm saying. 1718 is NHA. After that, it's only extrapolation. Only Shamika Ravi just brought out some unit analysis of the consumer expenditures, which has just recently come out. So, you know, one problem with the current government and why we are not very clear on the funding is the lack of data. Neither is it regular, nor is it credible, nor is it you know, reliable, because we are not able to know where they're getting what source, and NSSO has not done their health expenditure surveys. NFHS, of course, has something, but it's not the source we go to. So there is a bit of problems in getting data to really help people like Indranil to make a much more sophisticated analysis of what is really going on.
And so to summarize what you have said, the reason why health spending has been low is mainly because we need states to spend 8%, which they are not able to do because they don't have that liberty to spend.
Also, not liberty, capacity.
Capacity to spend.
I mean, will Kerala tax rubber growers, farmers? Then they'll get all the money that they want. But that's a political economy. So what is your capacity today to spend and raise resources in the current taxation schedule that we have?
So politically also, they don't have any incentive to spend on health because somebody living an extra year doesn't get them a vote. It's more about somebody getting a bicycle, like you even mentioned in your book. So it's more visible things that get people vote rather than a good quality of life, because that goes unrealized. And lack of data, which nearly every researcher in the country is talking about. We don't have fresh data to work on. And the next question that I had asked you was, then why does in a country like India, we have Kerala, Tamil Nadu also, and we have Bihar, Chhattisgarh, Jharkhand also? Why do we have these two extremes?
Well, you know, Kerala and Tamil Nadu, Kerala, as you know, had very enlightened kings. I mean, there is a certain history of each state, and health systems are very contextual. So Kerala had these enlightened kings way back. I think Rema will be able to be a better expert to tell you the correct dates. But the Travancore Maharajas had put education and health as a priority. And since then, the investments have been made. And then later on in the 50s, I know for a fact how doctors at that time pushed women to go to hospitals for deliveries, not home deliveries. It was a conscious policy for institutional deliveries. And that then increased their behavior towards health-seeking behavior, as it's called. Go to hospitals for any kind of treatment, and also the people of Kerala are much more alive and alert and more demanding on the health system than any other state. So that's a history that they have had over 100 years, and so they've always been high spenders on health. Not very high. I mean, if you really look at their figures, it's not as if they're spending a lot, but they're spending quite a bit, and they have a very vibrant private sector with which they're working. Tamil Nadu also has a bit of that, but Tamil Nadu, right from 1947, took on to public health. There was a one state, along with Maharashtra, which said that they are not going to disband public health, they're going to maintain the public health cadres. You know, and because Bhore and all had said, now remove all this public health and have PHC, CHC, and so on. And there was a conference of ministers. And Tamil Nadu said, no, we are going to stick on to a public health cadres. So they've always invested on reproductive child health, family planning, and they've invested on PHCs and sub-centers, you know, the village volunteer services and so on. So they have a very good, sound primary healthcare system, both in Tamil Nadu. It's a different way of doing it, but Tamil Nadu and Kerala have always had very good health indicators because they've invested on the primary healthcare areas for a long time. Whereas Bihar has always been a very poor state. Even today, they're 1/3 of the total GDP to compare to Gujarat or Tamil Nadu or Telangana or any place, you know. The per capita income of people, Bihar is 1/3, almost I think 30,000 is the per capita income, as opposed to 1.5 lakhs or something of Telangana and Gujarat. So therefore the poverty of Bihar has been so acute, and the infrastructure has not developed accordingly. So this is the reason why I believe personally, and I think many of them, there is a view that central government should go out of its way to make up for this historical disparity. I mean, when India won its independence, there's already a disparity between some states and the other. The British governed states were definitely better off than the non-British governed states, you know, in that sense. Not that Bihar was a zamindari, it was. I mean, they had a lot of huge landed property and feudalism. Zamindari was there. That was removed in 58 and so on. But the investment pattern in Bihar and these northern states was not really geared towards health and education the way southern states were. So there is a historical disadvantage that the northern states have, and the central government ought to take these factors into consideration, plus the capacity to raise resources and give a differentially much higher amount of assistance so that they do the catch up, which they are not doing. So since they don't do catch up, and Tamil Nadu gets 1 rupee, so does Bihar gets 1 rupee, almost on similar length. Always the disparity is higher and higher, and you know, goes on, and it never gets bridged. So unless and until a very strong policy from central government, which has all the money. You see, in 1947, when they did this division of financial distribution of functions and finances, the constitution makers were so afraid of the country cracking up if every state became powerful financially, that they kept all resources and defense, finance, defense, and external affairs was kept strongly with the union government, largely because 556 kingdoms were joined together into an artificial artifact called India. So you have to understand that history. And with the result, they did that, but then they also realized that the state governments are best to do education and health. So the responsibilities of the state governments were not in consonance with the money that they commanded. And so this, as they call, you know, the vertical and horizontal iniquity was built in right from then. Not with bad intention. The intention was to keep the country united, but then over the years, education, health has become very expensive, and the states don't have the money. So this imbalance has really affected the ability of the states to be able to really discharge their functions that has been given to them under the constitution, because they don't have the money basically to discharge it the way in which they ought to. So the central government has a duty today to review this whole thing in a historical perspective and step up its own funding in keeping with the demands of health and education that has now cropped up in a modern, society. After all, we have also had a disease burden shift. So NCDs have taken over. I mean, there is a epidemiological transition that we have made in 2010, which means that we have a far more higher disease burden due to non-communicable diseases than communicable diseases. What I can treat in TB, in say, or HIV/AIDS, I need 300 rupees per capita. For one case of oncology or cancer or cardiovascular, I need 50,000 rupees. So, there is, it's much more expensive. There are also chronic diseases, diabetes and hypertension. They go on and on and on till you die. So they have to be, patient management has to go on. So per unit investment on an NCD is far higher than a communicable disease. But when communicable disease hits you, it can hit you the way COVID did. So we have to keep watch on both. But in terms of money, this is the way the budgets have to be balanced.
So overall, the solution seems like the government has to put in conscious effort and increase funding.
Yes, to reduce disparities, regional disparities very quickly.
There's a question on in the chat which has come up, which Siddesh is asking how health cess has been managed in the recent years. Rema or Dr. Indranil, if any one of you would like to answer that question.
So I haven't looked at the health cess specifically because it's health and education cess. And Rema, if you have, please feel free to. A few years back, please go ahead. Yeah.
So the health cess that has been collected, the government gives you an account of it every year. It comes as part of your budget document, where they show you how much they have collected each year for these things. Usually it is shown together. Health and education cess is shown together. But if you go into the policy documents of the government, it clearly says that though it is 4% and it's combined, 1% out of this is for health. So we can separate out that 1% and you get to know how much is being collected for health. So every year, I mean, thousands of crores are being collected in terms of health cess. In fact, I mean, I can tell you that the health cess collected so far is, it's 97,231 since 2018. So that's almost 1 lakh crore rupees has been collected as health cess. Now, what the government has done is they have started a Prime Minister Swasthya Suraksha Nidhi, which is PMSSN. You will keep seeing that in the budget documents. It's basically they've started a fund in which they will deposit all the health cess that is collected, and that is being done so that it doesn't lapse every year. You can carry over the amount, what you don't spend this year, you can carry it over into the next year. But, and also, I mean, though the cess is being collected, and it is completely in the control of the central government, if you look at the points at which in the budget document, you will see where that cess is being used. It is being used for many centrally sponsored schemes, which basically means that a lot of it is also being transferred to the states. So, I mean, of course, it is within the control of the government. They can decide how much they want to transfer and whatever. So it's completely controlled by the center, but they are transferring. For example, Ayushman Bharat is entirely funded with our cess money, by people, what people are paying as cess. Then a large part of your, what do you call it? PMR beam is being through cess. Then there are quite a few actually. And
PMSSY. PMSSY.
PMSSY is coming from cess. So many of these things are being transferred to states because, you know, PMSSY again is Prime Minister's Pradhan Mantri Swasthya Suraksha Yojana, which is basically to strengthen your colleges, or even the older colleges, not just the new ones which are being built, but also older colleges. So many of the state colleges, state government run medical colleges also get that money. So in that sense, some of the money is being shared with the states. The problem is that, I mean, it is entirely controlled by the center. So that is one thing. And the cess which is being collected was supposed to be a top up. This is my problem with the cess. The cess, when they collected it, they said that we need to spend much more money for providing rural healthcare for the poorest, and for that we are going to impose 1% cess on your income tax and on corporate tax. So that money which we are collecting will be used over and above what we give every year as budget. Instead, what has happened is they have progressively cut what the government is giving for health and used the cess money to hide how much they are cutting. Because when you add the cess into the budget amount, you don't realize how much the budget has got cut. So instead of topping it up, they're actually substituting the cut. So that is hugely problematic, because if they had actually added, and if they had spent the same amount that they were spending in 2018, for example, in 2018, the year when the cess was introduced, health spending was 2.5% of total budget expenditure of the central government, right? But that share has been reducing steadily. And this is despite adding cess. So in actual terms, I mean, what you are spending has actually been drastically cut, as in the gross budgetary support, what the government calls, that has been cut drastically by the government. And they are using what they collect, all the thousands of crores which are being collected through cess, they are using that to basically sort of, substitute for all the cut that they are making. So that becomes a huge problem, because from 2018 to 23-24, if you look at it, your share of total budget expenditure has been falling precipitously. It's not even like a gradual fall. I mean, it's a really precipitous fall if you take away the cess wala share. So that's the basic problem. I mean, cess could have made a difference. Cess was not such a bad idea. I mean, if we actually used it to buttress our health system.
So the picture.
Rema, if you can, since you studied this, I haven't looked at it very closely, but I was looking at some data, and it shows that of the cess collected, only 25% has been transferred to the states. So I don't know what the remaining 75%, as you said, is it going into the central government, like Ayushman Bharat and all that, or is it not being spent on health at all, which is what is worrying me, because they collect them in the name of the cess, but not give any money for health. In Thailand, they have a health cess, but that's largely for tobacco, and they use it all for, whole money is used for tobacco, anti-tobacco promotion activities. But here, in case this data is right, that only 25% of the total collected has gone to the health department, the rest of it has been hardpored by the central government in the consolidated fund. That means, they're using health cess for their own resources and not spending it on health. Rama, since you're looking at it, please do clarify that aspect.
So there was a story in The Wire about this. I haven't story because I haven't seen any proof.
I think Ram Kumar has done some work on this.
Yeah. So I don't have proof that the money has been diverted to anything else. I thought, I mean, in all fairness, I thought when you create a fund separately, that Swasthya Suraksha Nidhi, basically you're putting it in a fund which you cannot touch then, except for health. But I guess you're the government, you can do anything. So
yeah. So I mean, it's worth looking at this, because I read this somewhere.
Yeah.
25% only has been used for health. The rest of it has been taken off. Yeah. Your government or Malik, yes.
Yes.
Yeah, that's right.
But I have a small point to add. I think this has been fascinating conversation and very insightful. So once the cess money is now transferred to the, say, health department, Ministry of Health and Family Welfare, then it's very difficult to distinguish between how much is being spent by the union government, how much is being transferred to state from through the CSF. Or is it possible? I think it will not be at that stage. It will not be possible to distinguish. For instance, the only way could be that if there is a scheme which is entirely funded by Cess, which is like PMSSY, and there we see how much is transferred to state, then probably we can figure out. But that's also a very challenging exercise. But it would be worthwhile, like Sujata also said, to really look at the utilization and transfer of this cess scheme. We did it for earlier for education, and it was a really substitution that we saw in SSL.
No, here also, as Rema said, there's a lot of substitution. I
Yeah.
mean,
Yeah.
as she rightly said, it's supposed to be a top-up, not to save your
not-
budget. But then I suppose this is going on. But I'm saying not only not top-up, but they're also siphoning off our money. Yeah.
That, like I said, I think we should look closely into that. But actually, the people who can actually explain whether there is siphoning is people within the government. But this government, I mean, the crackdown has been so hard. There is so little oversight that even bureaucrats don't dare to say what is happening within it. And CAG audits have become few and far between. I mean, in every way, I mean, oversight is discouraged. Let's put it that way.
I think the health cess is collected, goes to the finance ministry directly. So I think there could be some data if one looks closely in the finance budgets, perhaps. Because after all, this data which I saw 25% being transferred must be from some place where it is located. I don't know. I haven't really looked at it. No idea.
Yeah, worth looking at, Sujata. In fact, I'll talk to the person,
Yeah.
Kumar, yeah.
So overall, if we take the medical inflation into account, and this now the whole idea that cess is being just substituting health budget, the scenario could be way worse than what we are currently aware of. So I mean, so there was another question which came up. Kiran Kumbar had asked this, which is a very simple question. So where is our money going? If all of this is not coming here, we have seen education funding has gone down. We have seen health funding has gone down. So ultimately, where is the money going? Sujata ma'am, if you would like to take that off first. And
where is it going? I mean, if you analyze the budget, it is going for defense, it is going for what do you say, for all these popular schemes. After all, we are spending how much on the food subsidy? That 5 kg scheme for 80 crore people, that's causing almost 2% of GDP, I think. Another 1 point, so out of, see, our tax to GDP is a figure that you all must look at. Now, tax for GDP means out of the total GDP that this country has, say 45 lakh crores or whatever it is, how much of it is contributed by tax? And how much of it is contributed by generally all of us producing wealth, right? And that tax to GDP ratio, as far as I know, is about 11 to 12% still. I don't think it has increased. Whereas European countries have a tax to GDP ratio ranging from 19 to 30%. All these Norway, Sweden, and all of almost 30 to 35% is the tax to GDP. So when they have so much of money, they're able to provide almost, social health insurance, NHS, all this business comes in when you have a huge amount of money to spend by the government. Now, in this, tax to GDP is so low, the government's earnings are so little that out of this, health is competing along with several other departments.
Yeah,
And
but
that's the
Sujata, I
reason.
mean, as lots of people have suggested, nothing is stopping the government from taxing the 1%, which is the richest.
That is different. The current structure of taxation,
Huge amount of money.
you have your wealth tax, you can have all that. Why do they give 16 lakh crore waivers?
Exactly.
Why is the corporate tax? So then, what I'm trying to say, then you have to look at the macro indicators, macroeconomic indicators of where exactly is being let off, and who is what is the money left for spending on for people's welfare. After all, you have foregone 16 lakh crores, you have reduced your corporate taxes, you're collecting more and more and more through indirect taxation, which is a very regressive form of taxation, where a rickshaw puller pays 1 rupee, the same 1 rupee Ambani also pays, and that's why it's called regressive. Whereas direct tax means I earn 5 lakhs, I pay 30% of my money. Whereas if you're earning 20,000, you don't pay any tax at all. So that's called progressive taxation. Now, in this, indirect taxation is a dominant form of money being collected by the central government. Now, therefore, they at the same time, having said this, the opposition is saying that you're not spending enough on defense. So where is the money means the whole structure of financing itself has to be studied to see what are the subsidies being given, how much are we really spending on welfare, because even on education, they're supposed to spend 6%. They're hardly spending 4%. So it's not as if any welfare programs are being done. Welfare programs are hardly 19% of the total spending is on welfare, if I remember my data. So, you know, the rest of it is going in all this infrastructure. How much they're spending? 11 lakh crores on useless roads. Why do you have to go on making roads for whom? I don't understand. So 11 lakh crores.
Ahmedabad,
Roads and airports. Look at the airports, your bullet trains, whereas your Jatka train doesn't move, where, you know, common people have to go. Both Vande Bharat and bullet trains are for the rich. So not only what are you spending on, but in that, what is your priority? Who are you spending it for whom? So this is a very fascinating analysis that needs to be made to say what is the room available. I mean, like, if you became a prime minister also tomorrow with full powers, can you really make 2.5% allocation for health and GDP? Not in the present structure. You have to have a very strong political will to say, I'm going to stop these unnecessary subsidies. I'm going to stop all these giveaways to the corporate sector. And this kind of, you know, a whole paradigm has to be changed.
Yeah.
Sorry, one point I wanted to. So the effective tax rate, if you look at, say, for the corporates, is actually one of the lowest in India. Effective tax rate means when all the exemptions and concessions are taken into account. So, not to say that every concession and discount are unnecessary, but I think there is a lot of scope for rationalization. There is scope for implementing one more point. Even if when we want to add, say, reach 2.5% of GDP, we also need to empower our local bodies. This is one point I want to bring in. Even, like, say, local bodies spend only 2% of the whole public spending on health, which is already very, very low. And a lot of public health preventive interventions depend on local bodies. With increasing epidemic, the climate change, dengue spreading across smaller towns, you see deaths which are unaccounted for here, because there is a public health system that can respond to it. And there, the role of local bodies need to be really strengthened. And I think in this process, we have to also think about the role of Finance Commission. Finance Commission probably at this point need to give more resources to states and local bodies to strengthen primary care and public health facilities. So that's where probably a lot of emphasis is needed if you ask where to spend the money from. One more point I want to bring in here, and this is also deeply concerning, that the share of union government money going to state governments on health. So out of say 100 rupees spent by union government on health, how much they were giving to state government, that's coming down continuously as a share. Some of it is to do with the Finance Commission readjustment, reorganization of centrally sponsored schemes, but also probably there is a lot of centralization happening at that level as well. We would do things directly rather than empowering the states, and that's where probably much of the action is needed. Yeah.
Also, when we were talking about the difference between various states and why one state is different from another, I think we miss out the fact that both Kerala and Tamil Nadu have very strong social movements, have had. And that has made all the difference, because, I mean, finally, if the majority of the state are completely suppressed and have no representation in any of the arms of the government, are not represented in any of the decision-making bodies, then the decisions taken also will reflect that. And both Nadu and Kerala have, I mean, out of various processes of history, have had very strong social movements. Which have fought against the feudal system, which have fought very hard against the caste system. And I think we are reaping the benefits of that. And any state which you see is very backward has zero social movement, or very poor, very ineffective social movement. Like Bihar's feudal structure hasn't been broken. You can see that even today when you go to Bihar. But for example, in Rajasthan, which has a vibrant NGO movement, there is still a possibility of doing a lot more things because the social movement is there. So I think health especially is so strongly tied to how strong a social movement you have.
And this is a question which has come in the chat as well, where Neha is asking that what is the role of then the non-government actors, which are NGOs, CSOs, and what is their contribution to community health? And are we growing? Is our dependency on these growing now that the government is stepping back? And so, to what extent would this absolve the government of its responsibility? Because now we are NGOs and CSOs; they are becoming taking over community health.
Also throttling a lot of NGOs and CSOs and shutting them down. And I think Sujata's experience in NACO, where a huge success was because the government listened constantly to feedback coming in from civil society. And then, the policy was always responding to what was coming to them, the feedback that was coming. She can speak much more about it than I can do. And the fact is that this government is throttling any sort of opposition or any sort of criticism coming from civil society, which is the only way you can get some feedback from the ground.
There's another question in the chat. Dr. Indranil, if you want to say something.
So on the point on role of feudalism and any progress, and I think Rema made a very excellent point. I want to add to this. See, medical fraternity, the health workers, be it the doctors and also nurses, or at various levels throughout the world, if you see world history, they have made a lot of difference in terms of how healthcare is provided through their own movements and agitations, political intervention by the doctors and the other medical health workers. And here, feudalism play a very critical role in India. The whole the policymaker category of doctors are full of specialists who belong to a particular strata, the upper caste, upper middle class sections of the society, highly connected to the political class, and they play a very critical role in holding back any progressive change. And that we have seen in Rajasthan, that tussle happening. But Rajasthan, like Lima said, there is a civil society, there is some progress happening. But in many other places, if you go to particularly Bihar, the caste system or the control of the feudal elites or elite capture, what we call, on the health system is so deep rooted that any change you want to make needs a lot of extra effort. If you want to centralize the procurement system to bring in efficiency, in the sense the state procures for all the districts, that also gets very vehemently prevented because of the elite capture. So these are deterrents that play, and that's why probably the progressive legislation, the recruitment of doctors, and then say medical education. The progressive policies in certain states have also, along with civil society intervention, have played a critical role in democratizing the health governance, bringing pro-people orientation. And then, of course, the role of NGOs in that context. We have to also, just to respond to that particular point, in terms of care, the most backward areas of the country, Chhattisgarh, tribal Odisha, Northeast, there are in eastern Maharashtra, there are civil society run, NGO run hospitals who are playing a stellar role in providing healthcare to the most needed sections of the society. Their role is estimated, but they play critical role in certain parts of the country.
No,
And it's
Really,
yes.
I differ with both of you. I think the civil society today is in a very bad situation.
Sure.
There are two propositions I want to make. One, there is no getting away from the fact that the government has to spend. No getting away. You cannot leave the field, as you're saying, Parth, that, since the government is now backing off. If it's backing off, it's giving not space to civil society, it is giving space for corporate sector. And we cannot have corporate, private, commercially ridden, profiteering institutions like them to have health policy in their hands. So when Indranil was suggesting only a bunch of doctors are in the policy table, it is these corporate leaders. and the CII and so on. So they come with a very strong vested interest of profiteering from health and medical education. So first of all, there is no question that government can withdraw. They have to spend more. I think there are only about 15 countries in the world that spend lesser than us in terms of health spending against GDP. It's a shame. If you want to be what? 5 trillion economy and third largest or second largest, this is rubbish. So, this is absolutely something that's a no-go. Insofar as civil society is concerned, with all these rules and regulations about which you are aware, almost 25,000 NGOs have been shut down, including institutions like CARE, which have huge amount of money to spend whole of Bihar health system. They spend some $100 million and so on. So, the point here is that even the mission hospitals, which have done a lot of work, and as Indranil referred to some private, NGO hospitals in Chhattisgarh and so on, they're struggling for money. Now, the government tells them you go to CSR. But in CSR, again, the government has become a strong competitor. There again, the government is saying, no, you give money to what we give you as priority. So even in CSR, like whole Tata CSR goes only for PM cares and government programs. So, the civil society today is hamstrung from all sides. On some plea or the other, they shut down. Their funding has been completely from foreign funding. It has come down drastically. The Indian government doesn't give any funding, and their ability to go for CSR funding has also been constrained because government is competing with them. And government said, for example, all the who has CSR money, your oil companies, for example. So all oil companies, and 1 year the money went for toilet program. That's Swachh Bharat. So where's the money for civil society? It's a good program. I have nothing wrong with toilets. But what I'm saying is, where is the source for civil society to mobilize funding and do any work? Because health is a labor-intensive activity. You have to have workers, you have to go to the village, you have to pay costs. Today, that voluntary service to do on pro bono business has gone. So civil society as an active player in health is got to be read with inverted commas. So, and if they are there, that's good. Now, when Rema mentioned NACO, we had 25% of my budget went to civil society. That means the communities, the sex workers, associations, the MSMs and so on. No program in the government gives any money at all for civil society today. So with the result, neither are we giving panchayats and strengthening them, as Rema had mentioned and Indranil had mentioned, nor are we enabling and facilitating civil society to mobilize money from throughout the world to, as additionality to what the government is spending, nor is government allowing them to raise. So it's in a very bad situation, and I think this we need to, raise awareness about this issue. I don't see any conspiracy against it, but it's just that different policies are not working in tandem. They are at contradiction with each other, with the result, overall, we are creating problems.
Yes, Dr. Indranil, do you want to say anything?
No, of course, there is no difference in that. I didn't mean to say that civil society can substitute, but yeah, of course, a very critical role, like Dr. Sujata has mentioned, would be played. But then the state has to step up its act, and also state has a responsibility to democratize the health space. Without democratizing health space, it needs a lot of investment, but it also needs a governance mechanism which has a lot of people's participation at every level, and it cannot be a central police state, but a very democratic bottom-up state that we need, and that's where probably civil society can play a very critical role. Not to substitute government in terms of providing things.
So overall, we are closing in on the 1.5 hour mark, and this discussion has been so enlightening. We have learned about how health is financed, what are the barriers, and
crash course on health financing.
Crash course on health financing. And now I quickly want to jump to solutions, because we have discussed the problems a lot, and now from each of your perspective, from your backgrounds, from the role you play in the community and at your workplace, what do you think are the solutions moving forward? I will start with Sujata ma'am.
Solutions. Solution, as I've been saying all along in all my comments, that there's no substitute for the government, both state and central level, to step it up. No more pushing problems under the carpet. No more, neglecting health. Health is really one of the most neglected sectors. And the sooner the governments realize that neglecting health has a long-term implications which can be very adverse to its own growth. Because, if you look at labor productivity is increasing due to ill health. So even if you look at it only from the rupee Naya Paisa kind of investment lens, not just the ideal level that I have a social contract where every citizen I'm duty bound to ensure is well and healthy and able to live to his optimal best, even if that idealism isn't there, even in terms of rupees and Naya Paisas, if you have all these population, the young population sick and unwell and taking, leave from work and loss of productivity days is more than 12 to 14%. This doesn't make you a competitive economy at all. So you're losing a lot of young people to TB, to sickle cell. I mean, these are all small diseases with small budgets that you need. Even that we're not able to cure, and not able to handle. So I think the amount of money that Indians are spending, you see, household savings have come down. Now it's 5.5%, which is lower than 7-8% that it was. Why? Post-COVID. Much of the money went in keeping yourself alive. So, more hospitals, I'll just tell you one point. More hospitals, are much more growth momentum coming due to the health sector is not a compliment to society. Because what does health do? The money we are spending on health is only enabling you, sick fellow, to come back to your original state of health. Right? More factories and manufacturing industry has to come up. That is the healthy growth of economy. Not that I have so many hospitals and so many sick people and so many drugs that people consume is not a sign of health. So of the economy. So therefore, much of the money people are spending is going on buying drugs, on going to hospitals for hospitalization. And therefore, I think government has to step in. They have to improve the public infrastructure and really focus on health. Because if you really begin to calculate the loss to GDP on account of ill health, disease-wise is huge and stupendous. So I think this is my solution, that government has to really take this seriously. And it's not a question of health insurance. Every political party makes 5 lakhs, 10 lakhs, 15 lakhs, 20 lakhs, 25 lakhs. What's the point of, what is insurance? Insurance is a demand side strengthening. That means today I have power to spend up to 25 lakhs, but where is the supplier? I can spend 20,000 rupees on buying mangoes, but if there are no mangoes, what do I do with the 20,000 rupee voucher, right? So this is a lazy way of saying I'm doing so much for health because I'm increasing the sum assured insurance package. But where is it? In Bihar and Shravasti and those kind of East UP and all, if you go, there's nothing, means nothing. It's blank. No private, nor public. So what do those people have to do with this wonderful health insurance schemes?
Dr. Indranil, coming to you. Researchers like you, economists, what do you think is the role going forward?
As a policy analyst, I will say a few things and what we can do as researchers also. But I think, of course, in public spending need to increase, health governance need to be democratized. There is no good health without a democratic health governance. But also we need very good data. We need data to plan, we need data to do research and show the reality, and that's our job. We are constrained by the lack of data. So we need to demand more data. I hope every public health researcher does some budget crunching and tell the government that this is where your priorities are. This is how it should be. Uh, Having said all of that, in terms of priorities, I think Finance Commission need to play a critical role in financing of health, and it need to provide more support to the local bodies, panchayats, urban local bodies, and much of that money should be like Sujata ma'am said, to keep people healthy. What do you do? Preventive public health interventions and primary care needs to be strengthened thoroughly. In urban areas, the challenge is even worse. There is a competing perverted healthcare that is being provided through semi-skilled and even corporate hospitals. So our challenge is even more to expand preventive primary care in urban areas. But the climate challenge, emerging epidemics, the non-communicable diseases, so we need a more serious approach towards health, and there is no other way but to bring people at the center of health, being provided by people, being like they should be the guardian, we should be the guardian of our health, and that means government provides care, but the accountability is towards us as citizens, as every citizen. And we need more data. We need the census immediately. We need regular publication of consumer expenditure data. The NFH's data need to be given that independent space that it deserves. We need data. And also the last thing about data only, this without centralizing data, you can still do a lot more health decision making. The digital health mission needs to be relooked at, and the districts need to be the level where much of health governance planning takes place. We need to strengthen that capacity at the district level, and that's where probably public health cadres, public health people trained in data can play a critical role. But I'll stop here. Thanks.
Nema, your turn. What do we expect from journalists, media, and the common person? What
Be like Rema.
Yeah, I guess what can journalists do? They can only write about it. I mean, in the hope that, I mean, somebody is listening, the government will act on it, that the people will actually put pressure on the government. But then, I mean, there are people and there are people, because public is not, there is no one public. There is a public which actually uses government hospitals, and then there is a public which reads the newspapers, especially English newspapers. Most of that public is definitely, most of them are not going to government hospitals. So there is public and there is public, but still you write in the hope that, I mean, at least if these guys are at the level of policy making, it would make a difference to them. And also what you write, I mean, when journalists write, you hope it gets picked up by people in the vernacular medium, like, any of the local languages. If the local languages can pick it up, their reach is, probably 10 times, 100 times more than what any English paper can hope for. And now papers itself have no reach compared to digital media. So you're also hoping that when you write and if you put out the analysis, some of the digital media will pick it up and they will, help to spread it much further. So there is digital media, there is TV, all of these people with much, much more reach. So you write in the hope that, I mean, it'll get through to somebody. But like I said, there is public and there is public. And definitely the ones who are reading our newspapers are not the public using the government hospitals. And no matter how much the government projects that, their budgets have doubled, the propaganda goes only so far, because when the public which is actually using the government hospital, when they go to their hospital, they know if it has actually made a difference. They know if it is, from their experience, if the money is actually being spent on them. That's when you see the difference, when public actually gets upset about it. But only an empowered public gets upset. The others accept it as fate, that this is what they're fated to put up with. So there is also that I mean, if there is a social movement, if there is an empowered public, then they can hold the governments to account.
But I think, both Indranil and Rema can do a lot, because, as one chief minister used to tell me, you have to build the environment for policy change. And this environment building comes with data analysis more and more, as Rema has said. If these come up in social media channels and paper, I'm not saying Rema personally, I'm saying the profession as such, spend some time if our wonderful TV media could get away from their silly nonsense and spend a little time on health and what's happening, it does definitely go to form public opinion. And all politicians, every political party is very sensitive to public opinion, you know. I mean, just look at this 18% GST on health insurance. I mean, can't be more ridiculous than that. So there is now a public opinion coming up saying, why are we paying so much? And the middle class is feeling affected because they are the ones who buy private commercial insurance. So, you know, maybe there will be a policy change accordingly. So the point is, no policies will change just because it's good or rational. It will change only when there is a pressure from below and from the public. And that's where good quality research, good quality data, good quality analysis done inside universities should get disseminated to REMA kind of people, who in turn must then disseminate it through mass media channels. I think this is how the chain has to work. And that's where your hospital, your students, I liked what all was listed out by Indranil also. Look at estimates, look at analysis, look at district data, and begin to do papers on, you know, take any district, look at the epidemiological data, look at the budgets that they're getting. As he said rightly, districts are large and they need to be empowered with data. And our weakness in our country is data. It's impossible to do any research in government because it's very difficult to get data. But this is where we need to do close analysis, ferret it out from different areas and come up with policy papers and options, you know. I still, for all that we have said, and I have every reason, I have retired a long time back and I have every reason to feel cynical. But the point is, I'm very optimistic. I really, really think that there's still a lot of room for bureaucracy to maneuver and bring in good policy. I still think there is room for policy to change. But then there has to be that pressure from researchers and journalists to make that change. How many journalists are like Rema though? Rema, in your own family of journalists, many of them are so enamored by Apollos and Medantas and corporate sector and the CII. They don't, you know, so there again, a lot of exposure like the NGO can do is to call journalists, and Rema can help you gather them and give them a certain understanding of what is health policy and what are we doing, like what we discussed today. You know, they also don't get enough information. They just think that a nice hospital has come up, robotic surgery is being done. That is a state of the art. Yeah. You know, but that is not what is required. That is not what we should do in our country today where we are. Where is disease burden and what is affecting? And if one COVID or one TB patient is sitting in a village, you can die of it also sitting in Delhi. They need to understand that. So I think you can get doctors and social medicine types to come forward and do a lot of talking to judiciary, a lot of talking to you know, journalists and so on, who are influencers, the social media influencers and so on, to say why it is so important and have more discussions with these people, with these groups of people. So sorry, I've taken a lot of your time. I'm so sorry.
So this was a brilliant discussion. I think this is a very positive note to end on, that there is hope and things will change if we keep working towards it. There are, like you asked, how many people are there like Rema who are journalists? I see a couple in the audience. There is Shreya Raman and Swagata was there. I think she just left. They are doing brilliant work.
These are all the converted ones, you know, you have to get the others. Swagata and all of them like Rema, they are already on your side. What you have to get is the other gang.
So hopefully listening to them today will inspire a lot more journalists who are watching this video. And I hope that we will eventually bring a change through this 1 degree shift that we are aiming for every day. So thank you once again. This was a brilliant discussion. I didn't even finish all the questions that I had for you all, but we already crossed 1 hour, 45 minutes. And I think we have covered so much more than I thought we will. Thank you all for your time, and everybody in the audience. Do check out our website. We write a lot of on-ground stories through which we try to convey public health information and data. So nivarna.org. Nothing is behind a paywall. We believe information should always be open access. So do check out our work, check out our videos on YouTube, our previous discussions. Our next discussion is going to be on autism. And we have another very interesting panel of a teacher, a pediatrician, a mother, and a doctor, and a community pediatrician. And that will be happening soon next month. So do sign up to our newsletter and our social media platforms so that you can get the update for that one. And yeah, I would just like to end it here. Thank you all once again for your time.
Thank you. Thank
Thank-
you. Bye. Bye, Rema. Bye, Indranil. Nice
Bye,
meeting
Indranil.
you. And thank you, Path, for getting us together. Bye. How do you get out?